what I want to do with this last lecture here is, I will end where I at least think that we should always begin an ethics course, is talking about personhood, just real briefly, and the dignity of the human person and how we should understand that in terms of capacity. But what we'll look at here real briefly is different ways that competency can be determined, not I should say be determined, but weighing it out between a person's autonomy and beneficence, making sure they get good treatment. And after that, we'll look a little bit, not so much at mental health per se, but we'll look about how capacity is affected with the young and then with the old. So I understand that you all have already been exposed to the mini-cog test, so that won't be anything new to you. We'll just kind of go over that real quick. And the very last thing we do today, well, just to look at about how the medical field in the last 50 years has treated this balancing effect between capacity and autonomy and beneficence, and maybe make some real general predictions about where it might go in the future and why. All right. So anyway, that's what the balance always is. You're sometimes between a rock and a hard place because you have two goods that are competing. You have the good of the individual that has a right to autonomy based on their dignity as human persons. And then you have the fact that they're not going to have the same levels of expertise with the medical care team that's working with them, who wants what's best for them. In other words, beneficence. So how do you do this? I mean, how do you do what's in the best interest of the individual if perhaps they don't understand it or don't think it's in the best interest of themselves? Because you still have to respect their decisions, even if that decision perhaps is not going to be the best for their healthcare outcomes. So we're always trying to find ways to do this. And I found one study, and I'll share a couple of graphs with you. They're not mine, but I'll share with you at least to give you an idea on how competency in a legal term would be determined. Because capacity is something that we talked about before that could wane a little bit, and it could be enhanced also. Just remind me, I didn't talk about that in the last class. But with competency, it's like a light switch, right? I mean, there's not really like variations of this. So when a court decides and determines a person is incompetent, that's it. It's not, well, you're just incompetent this much. With capacity, we could talk about diminished capacity. We could talk about ways of enhancing capacity, but not so much with a legal determination of competency. And this is an obvious fact, but it's still one worth repeating, that unless you have really good reason to suspect a person has a level of incompetency, it's assumed that they're competent, and it never really comes up, nor is it an issue until there's something, that the patient wants contrary to what the medical team thinks is in their best interest. So the minute that there's some sort of discrepancy between what the medical team thinks is something they should pursue as far as a treatment or a way to, say, a procedure to help their condition, and what they want. So those types of things start to trigger an investigation. And by an investigation, I mean, you'll start obviously with capacity, then move on with the psychiatrist. If there isn't going to be any legal issues, then it'll go off to a court from that point. So what I want to say here is this. I'll give you these two diagrams, and they're not mine. And I think I'll try to clear these up for you. I pulled them off of a study, and if I read the study right, I'll give you how I understand it. If I'm wrong, I'll have to own it, but it's what makes sense to me. It wasn't as clear, I should say. If the courts make a determination that the more serious of whatever it is that's coming up, the procedure or the treatment, then we're going to raise the level of capacity proportionally to that. So that line that you see in a diagonal going up, that's the threshold. And you're going to see the threshold rise, as the decision becomes much more serious. Now, this tends to make sense in a particular way because, if it's not that serious of a thing, right? If it's, okay, every operation is serious, I realize that. But if it's a knee operation or such, or something that's going to help with mobility, you might have a lower level or threshold of capacity. It's going to be something where, it's life-threatening, like, say, that case study that we did in class last time, where even though it wasn't imminent death, if the person doesn't receive particular care, they could die. That'd be more serious if they were going to raise the level or the threshold. And if not, then the medical team is going to come in. So you would say as the threshold is raised, so is the autonomy reduced. And I would not call this paternalism, all right? Even though it seems that way, right? Because it seems as if the medical team is trying to make determinations. Well, this is a legal finding. What they're trying to do is they're doing what's in the best interest of the patient, and they're trying to weigh that against autonomy, and they're going to increase the threshold of that incompetent determination based on the gravity of what's in front of the individual. That's one. Okay, that's one approach. Now, another approach is what they would call the margin for error approach. So what you can see is this bottom line here. They say, let's just raise the threshold overall, right? So what we're trying to do is we're trying to reduce the margin of error. So we're going to, we still are, oh, by the way, let me just say this. You could almost, you've had enough little ethical background in this course that you see what's being applied here. This is principalism, right? You could see with that first balancing approach, no deontologist would make a determination like that. It would favor autonomy because they believe that that's based on the dignity of the individual. But in principalism, right, you're trying to weigh some of these factors, and autonomy and beneficence are of those. Consequentialism, maybe in rule consequentialist, perhaps, but it would just depend. Virtue ethics, that may not be so bad. It would depend on how they play all this out. And of course, it's hard to apply that in a very general sense. I'll talk about this next one. I'll give you a few more tidbits on it. And then I want to tell you why these things have to have some sort of standard, even if it doesn't seem like it's going to help us in every particular instance. We're still going to have a lot of circumstances to weigh. Okay, so in the margin of error approach here, if you can raise the what they're going to call the level of legal capacity, what you're hopefully doing is you are decreasing the margin of error, and there's an issue with this. So what in essence they're almost starting out favoring beneficence. That's how I would interpret this. In other words, if we were to drop that true capacity back down to the bottom line, we would be favoring more autonomy. If you're raising it, you're favoring more beneficence. The problem with the margin of error approach, there's problems with every approach, but the criticism of this particular one would be that you're going to increase incorrect decisions, all right? Now, when I say pros and negatives are positive and negative, it's positive if the person has been determined incompetent, all right? So if this will raise the positives where the person has been determined incompetent. It could also raise the negatives where the person then might enter into particular harm. So you realize that this is going to increase more incorrect decisions. But the argument that they make for this is that if you raise the instances of incorrect incompetency, then if the person is declared incompetent, then their autonomy is going to be reduced, and the medical team is going to be able to give them treatment that they think is in their best interest. And that's a problem because it does reduce their autonomy. But the people in the study are saying that's a different type of harm, right? So when you reduce a person's autonomy, in a sense, that's a harm. When you allow them to make a decision that's not good for them, that's a harm too. But reducing their autonomy is a different type of harm than allowing them to choose a course of action that's not best for their health. So again, this is not paternalism, but it's favoring autonomy. I'm sorry, it's favoring beneficence. I don't know how else you would interpret that, right? Does that kind of make sense? I want to make sure you make. Now, here's the thing: is you need some. We can't allow every situation, even though it has particular circumstances, just be determined by the people that are involved in that. Individuals need some sort of guidance. So what you have is you have to have some sort of rules or approach that a person can enter and use these things to help at least help the individuals to assure that they're going to do the right thing. We're in the middle of something right now in our country that's a perfect way to explain this. Like, for instance, we are struggling right now between two goods. Our two goods is that we need to make sure that we don't spread this virus. Everybody's quite aware of that. But we also know that this is going to really, it's not just being worried about money. There's a lot of other issues about shutting an economy down. You have people with, maybe zero income or very little income. There's going to be a trickle effect from this, right? I mean, you think of if you're graduating today and you're in a nursing field, you might be okay. But if you're graduating in some other field, you might have some issues over the next year trying to get into a decent position. You'll be fine if you're going to grad school. So how do you weigh these things out? Um, you know, it's good to hear. So if you hear a lot of arguments and it sounds like they're competing arguments, that's fine. And it's actually a good thing because people are ironing this stuff out. And you're letting various governors try to make determinations on what's going on in their state because their state circumstances might be different. So we know that as a one size fits all won't really work. But you don't want every individual community kind of working on their own standards, even if the circumstances of that particular community need to be taken into account. So you need some sort of overarching goals. So if you hear something to come out of the administration, I'm not here to support or condemn anything. If they sound vague, no guidelines from a national standpoint could be anything but vague, because the circumstances are going to determine the application of it. But you still want some guidelines. That doesn't mean because they're vague, they're not helpful. Same things here. If these two types of, say, the weighing out of the value, because you're trying to place some value on autonomy. Well, how do you place a value on something that's incommensurable like that? You can't say, well, if I have autonomy to this point, it's worth 8. If I have autonomy to this, it's worth 11. I mean, how do you put figures to this to measure all this out? We're almost like kids when our parents say, how much do you love us? We hold our hands out. I mean, what does that mean? We're just trying to say a lot. We have no way to quantify certain things. Well, that's what they're up against here with our health situation in the country. And that's what they're trying to put a value on autonomy. So you're making a determination, at least here with the margin of error approach. If we reduce the margin of error, we realize that we're going to have more incorrect decisions. But these incorrect decisions are at least going to cause a harm that's beneficent for the individual. So that probably would be the same application of trying to weigh out in our society today. We realize that you can't, it'd be one person's death is tragic. But if somebody were to say our standard is going to be no one returns to work until we are certain that not one person will die, it's impossible. We all know that's impossible. So we don't want to start making the argument, well, then who will that person be? And isn't a life worth something? We have to weigh out competing goods. It's the same way here when you're talking about a particular person's autonomy and an individual's, the gravity of their decision. You're going to have to weigh these things out. And you're going to have some incorrect decisions. But at least in this way, using the margin of error approach, the incorrect decision is going to be in the best interest of the individual, even if it goes against what they might think is their best interest. So you still recognize the harm, right? So what do you have any questions about that? I'm gonna, when I move on, it takes those two screens down. I mean, sorry, the two graphs down. So I make sure I left it up there until I knew you had no questions. Okay. Now, I originally was going to do something here with mental health, but I thought I'm just going to let that go. We'll do a case study in class with our text of Paul on mental health. We'll let it go here for now. There's no reason to spend much time with this. When you're under 18 years of age, you don't make your own medical decisions except for the various conditions that we've talked about in the past. Abuse, some maybe sexual disease, pregnancy, self-harm, those types of things. But it's impossible to get out of our minds that when you have adolescents that are nearing the age of 18, that we should always have in the back of your head when you're dealing with these individuals, that they have an emerging autonomy. So if the child was 6 years old, you would talk directly to the parents. You don't have to feel that you're slighting the 6-year-old. They're not going to be able to participate in the determinations that you're trying to evaluate. Maybe when they start to get to 10 or 11, you could at least, they can sit by their mother and you could talk to them both, but you're pretty much still listening to the mother or the father. But by the time you get to, 15 or 16, even though the parent's still going to hold the legal right of, over the child, so the autonomy of the adolescent is, through their surrogate or their substitute, or not a parent or guardian. But at that point, you still are going to side with the parents, but you want this child to be this adolescent to be part of the whole decision, because there's no light switch that flips when we turn 18, right? I mean, just because a person is now legally adult doesn't mean that you're able to make all these determinations that a day ago you were not able to. So there has to be some way to groom these individuals in a good and positive way so that they can build up a confident understanding of trust with the healthcare workers. Because I've shared with you before the studies that show how many 14, 15, 16-year-olds feel that whatever they tell their healthcare providers is going to be just told to their parents, which makes them very reluctant. And even when they get older, they might realize that was not the case, but you're still going to have some areas of time there where individuals are going to have to rebuild a trust or at least establish it. So the best you can do with somebody as they're emerging here and become 15, 16-year-olds, you involve them in it. So that's pretty obvious. There's nothing really there that we have to go over. I know not everybody in this particular class are nurses. So if I am saying something that's redundant to you, or if you want to chime in, please do. But for those of you that I can see on screen, you guys, you know the mini cog test? Do a couple nods. No, Sierra, you don't know the mini cog? Or okay. There's various ways to, now, first of all, this is this is a screening test. It's not something that's, a scientific test that's going to determine capacity or if a person should be at least be flagged to have a psychiatrist look them over. The mini cog test, I'll explain what it is in a minute, but it's a very simple 3-part test that can be administered by anybody with a basic training. So it could be a lay medical assistant. And if, by the way, if some lay person that was authorized to at least do it to the patient, whatever their findings were, they would report to the RN or to staff nurse or just the physician. An RN could do this, obviously, and the RN would then report up to the physician. So it's a screening, and it's something that's done. It's not a once and done thing. It's not like competency that's determined by a legal means in the court by a judge and a jury. It's determined it's a way to figure out what's happening with the patient and where are they at. Are they able to make particular judgments on their health? So the 3 parts are this. The first part is a 3-word memory test. So you would say things like, I'm going to repeat 3 words to you. I'm going to say 3 words, and I'd like you to repeat them back to me by memory. Apple, watch, penny. And then you would allow the individual to repeat them back to you. And there's 3 parts to this. And each part, if they do it successfully, they get score. So either they get up 1 point or they get 0 points. So that's the first part, the word test. After that, you would do what's a clock test. You would have a sheet of paper with a circle on it. And I know this will vary a little bit. But what you'll ask them to do is you'll say, can you put the clock arrows in? And somebody in the last class said it's at 10:30. They were taught. If you go to the mini cogs website, for whatever reason, they say 10 after 11. I don't know why that is. They've done some study that for whatever reason that makes sense to them. So you ask the person, not little big hands, none of that matters. You just put the hands in there that tells me it's 10 after 11. And then you let them do that. And if they do it correctly, they get a point. If they don't, they get 0. Now you go back and you repeat and say, can you now repeat the 3 words that I told you before? The clock is almost like this divergent tactic. So you're really trying to just get their memory. So you ask them 3 words, they repeat it, they can do the clock test, and then you go back and ask them. So it's a 3-part thing, and they are then scored. Obviously, you can get 3 different scores. You can get a 0 out of 3, a 2 out of 3, or a 3 out of 3. So the 2 extremes are pretty easy, right? If they get a 0 out of 3, then that's a testing positive for cognitive impairment. Something's wrong, right? They can't get any of them. If a person gets a 3 out of 3, then they're testing negative for cognitive impairment. Now, if they get a 2 out of 3, it all depends on which 2 they got. And again, these are only screening tests. This isn't something that's decisional and it's going to end it. And I'm going to read this because the last class I repeated it a few times, and I got concerned that I was not repeating it identical, and I don't want to do that for you. Okay. If they get a 2 out of 3, but the clock portion is wrong, so step 2, then that tests positive for cognitive impairment. But if they get both memory words right, but the clock wrong, then that is a test positive for cognitive impairment. If they score 2 out of 3, but the clock portion is right, then they test negative for cognitive impairment. The 2 out of 3 has to mean that you get the clock right. Again, it's just screening. Now, it's all likelihood you'll be administering these, depending, I guess, on exactly what capacity you work. People are going to want to know how they did right off the bat. So you have to be honest, but you're also going to have to be prepared for the fact that you may have failed this. And even though this is not some drastic medical, test that has got bad news, still can make the patient feel a little uncomfortable, right? So be prepared to say, well, I don't think you quite did as well as you would like, but that's okay. We're going to do this again, in 6 hours or so, and we'll see how it goes. And if it happens again, say, well, we still didn't quite get you where you wanted. Perhaps I'll have somebody else come in and do this. So at some point, the individual's going to be flagged, that there needs to be a little further information as to whether this person has cognitive impairment. You need to be prepared for that offhand. My wife's father or grandfather, this is what I told you when they would come in and do this regularly with him, the nurses. He would write whatever words they asked him, he would write them on his Kleenex box. And then when it came back in, he'd grab his Kleenex box, and of course they'd ask him a different 3 words. And it was an older guy. He literally say, "Oh shit!" He thought he had him. He's like, "Oh, I got him." But so be prepared for that too. There's people out there that may have cognitive impairments, but they're still slick, and they figure, I can write this down and I'll get you. So you ask different words. So, is there anything else? Because some of the other students that were in the nursing program said they had other things to add to this that I didn't. Anything that you would like to add? Before I move on to this, what I do want to say, and I'll talk about enhancing, why this is so good is that it seems to be an effective screening test, but it also doesn't seem to be particularly sensitive to race, culture, ethnicity. So it's not one that you have to worry about. Of course, if a person, didn't speak English, that's a separate issue. You would have to, administer this in their foreign and their native tongue. But it doesn't matter if the person, is Asian, Hispanic, it doesn't matter. This seems to be something that doesn't get penned in per se. What I did want to say, and this is what I forgot with the last class, I just realized, was that, since a cognitive impairment could wane a little bit, even if a person is not in the best, they may not be in the best environment for this. So, you might find ways to enhance a person's cognitive ability. In other words, maybe they need to see this thing played out on a whiteboard thing. Maybe they need to see it in a video. Maybe you just have to come to them at a different time of day. I remember growing up, my mom was this little short Italian lady, and every time I was in high school, I'd go to her like 8:30, 9 at night. And I go, "Hey, Mom, can you help me with this? I'm no good at night," right? I mean, so people have different times of days that they feel this, and you might be hitting the person at the wrong time. Maybe you're getting them before they eat. This is where you have to start being like a little investigator in your mind and saying, what's a good time for me to administer this? So there are certain things that you can do, perhaps to at least enhance this, right? Give them a better shot, because you're not trying to set them up to fail. You're trying to make an honest assessment as to whether or not they could, how do you want to say, manage it. Well, I'm trying to let somebody in here. There we go. Well, let me make sure I'm not missing something there, because for some reason I think I am. But computer aids, videos, talks about simplified. You can't get more simplified than this. So anyway, any questions on the age concerns or ways perhaps to enhance their mini cog test? Then let's wrap this up. Now, we started this course early on talking about personhood, and I called it Ground Zero. That was the name of the article. Every ethics course I teach, whether it's ethics or morality, doesn't matter. I start with personhood and I end with usually personhood or beauty. We're not here to argue about what is or is not a person. What I'm trying to say here is that when an individual has been determined to have some level of cognitive impairment, I know that none of us in a setting like this would ever think less of them, nor would we probably think less of them if we were in the room. It's easy to have to treat them in a way that dehumanizes them. And in other words, it catches us off guard. You would never, ever, come out and say that, well, I'm going to treat this person like they're not here. But our actions may basically, let me put it this way. Once the individual has been determined to lack a particular, agency because of their cognitive impairment. As a care worker, I don't care what field you're in, you're going to have to find ways to, a psychological trick to make sure that you don't fall into a trap. I'm going to give you an example. That's not the medical field. So I think I shared with you before, one course I was teaching, a grad course, 2.5-hour lectures, and one of my students was a deaf and mute individual, and he had two interpreters that were signing who would sit in a chair and they would take 15 minutes on and off. I thought it was exhausting for them, but they did well. He was a very intelligent student, and after class, he constantly wanted to engage me in some sort of discussion. So he would, and he couldn't really talk, just, like a guttural type sound, but he'd get my attention. I'd go over, and this interpreter would say, he'd like to speak with you. Okay. So he would start signing because he couldn't, he could mouth, but I don't read lips. So he would start signing, and then the interpreter would tell me what he's saying. What would happen then is I would tell the interpreter, well, can you tell him? And I would start speaking. And she would say, no, talk to him. Now, that's obvious, right? But I had to make myself do this because he almost wanted to have a conversation at every class. So here's my scenario. He's looking at the interpreter, signing to the interpreter. The interpreter is watching him, but verbally saying what he's signing. And then I would have to talk back to the student who's not even looking at me, answering a person who's not looking at me when they speak. So picture this triangle where nobody's looking and speaking at each other, but in order for me to maintain an individual's dignity and not dehumanize him, I have to talk to him like he's an audible speaker. It's the strangest situation. And so, when the interpreter took me to the side and started explaining it, I stopped her. I said, I get it. I'm actually ashamed that I didn't just think of that. But even when I fully was cognizant that I have to do this, I can't tell you how much thought it took to keep looking at him and talk to him while he's trying to read my lips, but I'm not that articulate. So while I'm talking to him, he's not even looking at me. He's looking at the interpreter. And the interpreter's signing what I'm saying, and then he's going to sign back to the interpreter, and she's going to talk to me. But I'm not supposed to look at her. I have to look at him because he's really the one that's talking through her. Okay, so picture yourself in a room where you know that the patient may not have a high level of cognitive ability. At what point do you treat that individual like they're a third person in the room? I mean, that's a consideration you have, right? I understand that the person's sleeping or unconscious. We're not talking about that. But maybe like having to stand in a way where the patient's between you and the family. So that way you are talking to everybody. So the individual's still there. Even if the individual is like motioning for their spouse or their kids to answer you, it's just giving the person whatever level of control that they've already had everything else taken from them. And I share with you with my father-in-law who passed away over winter, that even though he was unconscious, I was very uncomfortable, when the kidney doctor would come in and talk so frankly. And everybody's having a conversation about this person who's standing 3 feet away. I didn't like that. And I didn't get in an argument over what he did or did not hear. Just the whole thing, because I forced myself to be sensitive about this, you start to become oversensitive, like you're like an ex-smoker, and then you want to point it out all the time. So that's what I wanted to say to you, is that none of us are thinking less of an individual because they lack agency. But it would be very easy for us to act in a way in the real environment. Because let's face it, you're in a fast-paced environment. You want to get this done. You need the facts. You need to relate certain things. You can't be in a conversation mode when bells and things are going off in the next room. So there's an easy path to take, and a path to take is I want to talk to the person that's going to get this done. In an emergency, yes, do that, right? Like if I was in a room and there's an emergency, I'll make up some, fire alarm went off. I'm okay. All pleasantries are aside. Let's do what we need to do. But that's not the case, except for an extreme situation. So it's just something to keep in the back of your mind, that if you always see this individual as a person. So if you can, this is the motto, right? I told you I was teaching this in an online course up in Maine, and the one nurse said she made a big banner of this and put it on her workstation. We treat persons, not conditions, because you never have a case. You never have, a diabetic in that room. force yourself to use names the best you could. Of course, the doctor or such may not know the names. You could say, Sally in that room. It forces you to always see the individual as a person, even if you, intellectually know they're there. It's just something that it's a good practice to. So, any questions on that? No, nothing there, right? Right. So we know 50, 60, 70 years ago, the medical field, the relationship between patients and their physicians were quite different than today. It was almost pure paternalism, right? The doctor knew it was best. They would talk about the individual in terms of this case or that case. We're going to do this with little regard for how it's being heard. They just, this is a problem. We need to fix the problem, almost like a mechanic's going to, fix your car, and how they do it. It's all you're worried about, that it's done correctly. Well, by the time you get into the 70s, and think of like what else is going on in the world at this time, right? You have a lot of civil rights movements, feminist wave movement. There's probably a real sense of dignity that's starting to surface, and it hits into the medical field. So you have a situation where you're starting to move away from this paternalism, and you see that it's not treating the individual as an autonomous agent. In other words, they're part of this decision. So you start to see a move away from that. Now, by time you get in the 1990s, and I'm speaking very generally here, right? But this really depends on particular situations, but as a general trend, I think these are true, at least from the studies that I read. By the time you get in the 1990s, you have physicians who are very concerned about the paternalistic past, especially if they were trained by these individuals in, med school and such, or they've been interned through these. So you start to have this idea that we're just going to present the patient with their choices, and we're going to let them make the choices. It's not like a hands-off thing, but it's almost as if, well, these are your choices. What would you like to do? Now, the problem with that is that independence model almost took it didn't take the physician out of it altogether, but it left the physician not being concerned about giving his own opinions, in the sense that his authority, his white coat and such, may just, in fact, by that itself, become a way to coerce this individual into what he thinks is best for them, right? So he doesn't want to push his paternalism. And we're in the midst of various strains of that today. So no doctors that is hands off. I don't mean it that way, but you have people that are, hyper concerned about overly influencing their patient. So there's a new trend that you might be able to say is coming up into the medical field, and it's towards what they would call the shared decision process. Now, it's not a shared decision process only between the patient and the physician. That's obvious. But it's about other people, the family, the parents, the children, the brothers and the sisters. And here's what it's based on. Everything that we do in this world is based on understanding the human person. It doesn't matter if we think that or not. I teach a justice course. You can't really say what is justice until you say what's good. And you can't say what's good until you say what's good for a human person. And you can't say it's good for the human person if you don't have an idea of what it is we're talking about. So there's no way to really get around this in ethics. So this isn't something that's religious and dogmatic, although it certainly could be, and it certainly is. In fact, in Judeo-Christian terms, this has been an ongoing thing for 2,000 years. And I'm sure in other traditions also. But this can even be something that's in, a totally atheistic or agnostic settings. So in one of my PhD courses, that was a philosophy of psychoanalysis, the professor that was teaching me at the time was a Marxist atheist. And she would make the point that the human person, part of who we are is that we're relational beings. Now, the whole time I'm thinking this is something that's been part and parcel of the Catholic tradition forever, but go on. So it's interesting. So psychoanalysis oftentimes thinks that, people that suffer depression and such, it's over medication. I think that too. I'm not overly cynical about it, but I do think that maybe the general practitioners aren't the best people to dispense that. It's hard for them to make these determinations. If anybody here in psychology, you are, Brian? Okay, so in the DSM-5, right, there's certain criteria that if a person exhibits, I think 3 or 4 of these over the course of 2 weeks, clinically, that could be called depression. But this professor was making out a different case, and I liked what she did. We live in a world where we think everybody needs to be happy, right? So if you read dystopian novels like Brave New World, Aldous Huxley, when they didn't feel good, they took soma tablets, right? It was they went on a soma vacation, they called it. So we had this idea that we should be happy all the time. So you see it now, like people are feeling isolated and such. But we realize oftentimes that a lot of the things that we're feeling that make us sorrowful are just part and part of life. And that's not to be cynical, that life's suffering, but it is, right? There's a lot of life that's not going to go our way. I know, like now, nothing. I mean, I'm not going to say anything against anybody who's seniors, but my mother-in-law, who's old school, grew up, as a single, grew up very poor, raised her only child as a single mom, and now that she has a granddaughter, her granddaughter's graduating from high school now. Her granddaughter is very upset about not having a prom and everything else. And one thing about older people is they have no regard for self-esteem. So, she told her granddaughter, "That's the least of your worries. Trust me, your entire life's gonna be full of nothing but disappointments, and this is gonna be the last thing you're gonna think about in 20 years." She's right. It's probably not what the young child wanted to hear, but nonetheless. So what the psychoanalyst and analyst said was, when another person is sorrowful, it could be for a very good reason, and maybe that's them reaching out to us because we need each other. Now that's very Judeo-Christian, right? In other words, relationality is part of what I talked about in natural law and our understanding of a natural inclination, our primary precept. So maybe when we don't feel well, that's a signaling for the other person, which means that none of us are in this by ourselves. And I'm going to ask this. Has anybody read John Steinbeck? Do we know who John Steinbeck is? I want to see hands. I want to see how bad our high school programs are. Susan, you know who John Steinbeck is?
Yes.
Good for you. You are now the only one so far. Have you read For Whom the Bell Tolls? For Whom the Bell Tolls. Have you read that?
No, I did not read that one.
Okay. Now, there's a poem in the beginning of that. You're saying, I'm playing gotcha. In the beginning of that, there's a poem by a 16th century, I think, a Presbyterian minister called, his name's John Donne. It's called No Man is an Island. It's a famous poem. I'll give you the insides of it. No man is an island entire of himself. Every man is a part of a continent, a piece of the main. Every man's death diminishes me, for I'm involved in mankind. Therefore, send not for whom the bell tolls, it tolls for thee. In other words, in the old days, when somebody dies, they would ring the bells of the church. People would say, I wonder who died. His point is, you did. Because that's how interconnected we are. So even in like psychoanalysis, they're trying to say that, we need each other. Well, this is spilling over into medical ethics. There's no decision that's being made that is simply between the physician and the patient. Yes, the physician and the patient themselves are directly, especially the patient, right? They're the ones that are directly being determined by what has been chosen. This affects everybody. Why not get everybody in? If you want to call it a team fun, I'm not big for teamwork type lingo, but that would give you a sense of what this is. So let the patient have the last word. But why don't we always set this up? So you see more so now of family meetings, right? So even with my mother, I remember when it came time for the hospitalist and the two interns to come in, they arranged it ahead of time that there'd be other people there. We want to talk to the group. It's always up to the patient. Their autonomy doesn't go out the window because of this. So you see the shared decision. You can see how this is quite different than paternalism. It's even different than the doctor trying to let the patient make the determinations and not interfere as much because they want to respect the autonomy. Now it's let's hear what the doctor has to say. Let a group of people hear what the doctor has to say. Let the group chat about it, and then what other information do you need? All we're doing here is really trying to ensure that not only is what the individual want being done, but also hopefully, according to one of our graphs, that benefits is not thrown out the window on their autonomy, because it could be that a particular individual might yield to their significant others or their children, depending on what they hear. So you just see a little bit of an evolution that goes on in this, and who knows what will happen in the future, right? So if you were nurses in the 70s and the 80s, you'd be having different experiences now. You're going to become nurses, in the 2020s. Well, in 2045, and I'm sorry to say it'll be before you know it, it's going to be a different medical world. And you're going to be saying, it's nothing like it was when I first got into it. This is always going to change, right? So anyway, Any questions on any of this before we do our case study? So I apologize in advance for not having a good one. Well, it's a good one. I apologize in advance for not having a positive one. Let's put it that way. What we have here, now this, you might have some good conversation here, I'm hoping. So this is what, it's like an extra 15 minutes in the last class. So you have a high school senior, Derek. He was on a date with Debbie, a junior who attended the same school. And after the date, Debbie decided that didn't want to see Derek anymore, partly because she thought he was too aggressive. So after the date, Derek constantly phoned Debbie, walked behind her at school, parked outside her house. I had to confess that last part was me in college. That's how I got my wife, by the way. So today it'd be called stalking. I didn't do that other stuff, but nonetheless. So Derek is seeing a psychologist, and he was diagnosed with schizophrenia. Now, he talks to the psychologist about his desire to kill small animals and also to burn houses. But he also talked about Debbie. He doesn't quite get why, Debbie doesn't want to be with him. And he even said that he thought that Debbie's put a spell on him, right? So he's not rational. Debbie put a spell on him, and he doesn't want to deal with her anymore, but he just feels compelled to. He doesn't know how to get over this. And he talked about setting a fire in her backyard, not to harm her, just to drop the spell. At one time, he said that if he could, he would like to kill her, but he quickly withdrew the statement. And he said he would never kill a person. He said, but I did kill 2 crows using a BB gun. I only did that so I can use those animals as a sacrifice to ward off Debbie's spell. Now, before we go any farther, there was a couple in the last class. Anybody here besides Brian in psychology that I didn't see? All right, so for those of you that aren't, you know that there's any fiction out there, any truth out there is stranger than fiction. Right? So whatever scenario we're coming up with, this is a real one, by the way. There's stranger ones out there. All right. So the rest of the story is Derek's behavior really took a turn for the worse. Now he's going up to her garage and writing the word bitch on the backside. And Derek at this point is arrested, but he's released right afterward. Debbie's mother and father are extremely concerned, as you can imagine. They made sure that their son and other friends always walked to school with their daughter, Debbie. They insisted that she would never go outside alone. They continually called the police who assured them that Derek was under the care of a psychologist and that the harassment should soon stop. Now, here's where you have no good news. Dr. Sutton thought that Derek was making progress. And she said he's taking his medications now. He's expressed regret that he ever harassed Debbie or her family. And he totally stopped talking about Debbie's spells, and he decided, I'm not following her anymore. Now, that's with medication. Dr. Sutton still is worried that he might be lying. Derek's making progress, but she believes that he might need more help and might still be a threat. She's wondering if Derek shouldn't be committed to a mental facility so he can have greater progress. Well, now 2 weeks have gone by with his treatment, and he's on medications. After painting the garage, he follows her to school and he shoots her in the head. Now, the other students subdue him right away, but Debbie dies. After the tragedy, Debbie's family decides to sue Dr. Sutton for not committing Derek. They believe that Dr. Sutton's care was negligent and that they should have been warned by the psychologist that Derek was a genuine risk to their daughter. So here's your question. Did Dr. Sutton have a duty to warn Deborah's family that Derek was a threat? Now, we can talk about this and you could argue about it. You can put your mics on and I'll be more than glad to hear what you have to say. And that's how, at least if nothing else, to start a good conversation. But the reality is no. And it's not because a psychologist is obligated to keep this underneath from all, threats. You have to start asking questions about what's specific here. When were the threats made? How has the patient been since those threats were made? Now they're on medications. What were the level of specificity of the threats? As far as I can tell in this particular case, the psychologist thought at worst case scenario, there might be a verbal outlash. You might start to say, yeah, but he did threaten to kill her. Well, but that was earlier, and he immediately withdrew that, and we'll get in and talk more about that later. So anyway, any comments on that? By the way, you're not going to get something like this on the final without, in other words, I'm not going to ask you to make such vague things. And if I do, then you'll have a little box where you can write something in, and if what you say sounds right, then you get it, right? So I don't expect, I'm not a legal expert, I'm not a lawyer. I don't expect anybody else to be that either, right? So as we move through this, we ask some legal questions. This is mostly just, an FYI. Like, this is a real case scenario, here has it played out. And I can give you my impression on what would happen, but I'm not giving you my impression as a lawyer. I'm just giving you what I would think, talking to friends that I have in the field, right? Okay. Now, was Dr. Sutton negligent by not seeking to have Derek committed? Should he have had him committed? While you're doing this, going back to the question before, should the doctor, psychologist have informed the parents? If you remember the Tarasov case, because that'll be on the final, right? Somebody might make the case that yes, because look, in that particular instance, there's a certain level of threshold that needs to be met. We'd have to iron out what that level threshold is and how specific must an individual be before the threat is warranted as we're going to breach the confidentiality. All right, we'll talk more about that here. Everybody was, I'm not saying getting these wrong. Everybody was disagreeing with what the case study showed up with. This one's by DeMarco, the guy that's in your text, by the way. And the answer here would be no. First of all, there's been improvement since he's been on medication since. He seems to be ironed out. Now, we might say, yeah, but if he was committed, then this wouldn't have happened. That's true. Well, we don't know that it's true. It could just happen later. But we could at least say, and we're going to have to worry too, and we could talk about what would you do as a parent, because what we do as a parent might be different than what we could do legally here. What's available to the courts, and I could share you, I'm not a lawyer, but I was involved in a particular case of my own that had to do with nothing nefarious, and I was with another friend in the court, and what I realized was that what happens in a courtroom is not rational. I don't mean it's not right. What I mean is it follows legal foundations. Even when I was trying to work through my own case, my lawyer told me, you will win the rational argument. As a matter of fact, he goes, I think you trip up the lawyer. He said, but I want to say something to you. Before you get excited and you want to give it a try, nobody in the jury is going to be a philosopher with a logics background. They're going to go by how they feel about how the whole thing plays out. And if you put the tightest syllogism together, that any logician is going to say, you're right, that's not how it works. So I had to weigh that out. And it was an eye-opener for me, right? Because you'd like to think that if you just make an explanation and this makes sense, they're all going to go with it. But that's not how the world works. It's what laws do they have and how are those laws interpreted. And that you never really know. You never know how the laws interpreted. Okay. So here's the thing with this. The reason why this is no is because this is easy for us looking back that something should have been done. But from a psychologist or psychiatrist point of view, I'm not saying this is frequent, but they might have a lot of instances like this. And if they were to breach confidentiality in every instance, God knows how long they'd be in practice. They'd be liable, right? So are they playing it safe? Probably, because they know that they might have a hard legal defense. So let's picture this going to court. Again, I'm not a lawyer, but let's just picture this going to court. Maybe the lawyer for Derek is going to say, did he make a specific threat about killing this girl? Did he say, I'm going to go on this day and do this? No. So what exactly did he say? He said he'd like to kill her. Oh, so he'd like to kill her like a general thing. And did he say anything after that? Well, he immediately withdrew it. So he made a general statement that like to kill her, and then said, no, I'm just kidding. I would never do that. And you think that was enough. So it gets a little difficult to try to determine what is the weight of this. So last class, there were a couple of kids that were in psychology too, and they were talking about, what do you do with self-harm? person is going to make any sort of claim about hurting themselves, you know, different scenario though, right? And by the way, what you would be doing, like in other words, the student said, and rightfully so, that if I, as a nurse, if that's made to me, I would immediately report it to the physician or somebody, in the hospital. I said, yeah, that's right. You would do that. You should do that. And if you were a nurse and heard this kind of talk, you should also report it to whoever is above you. But we're not talking about you reporting something because there's a concern. We're talking about a legal determination in a court of law. Two different things. Even if this went up to the psychiatrist, like if you heard somebody in the room saying this, a psychiatrist or psychologist would be brought in, and nothing may come of it because they might just say there's no threshold met, and there's nothing I can do. And you might in return say, yeah, but I'm concerned. And the psychologist might say, I'm concerned too. We should keep an eye on this, but we are bound by what we can or cannot do legally. In other words, the standard for a legal standard is not the same as a standard of concern. If this were my daughter, I have 3 daughters, so I'm Papa Bear here, right? I can guarantee you that school would have this kid 100 yards away from my daughter at any given moment. And if I even felt like I wasn't getting an absolute answer from the principal, my child would stop going to school that day, and they'd be homeschooled from that moment on. So, okay, that's me though. But and we're not faulting these parents for not doing that. But what we're trying, we have these situations that when we think something is wrong and illegal, and then we find that it's not illegal, it can build a little level of cynicism. And by the way, you're going to become cynical. There's no way around it. You're going to be hit up against the wall so many times, you're going to get to the point thinking, I don't know what the worth of this is. So, you're going to become mandatory reporters. I'm a mandatory reporter. I remember one time I had a student come to me and say, just in casual talk, sitting in a bar, the kid was out of school for like a few years, talked about his high school teacher having sex with 17-year-olds in the school and stuff. I'm thinking, what you just told me, I have to report this. I call it in. Guess what? That's not against the law. In Pennsylvania, the age of consent is 16. So unless it was forced, how many times do you think it's going to happen before you start becoming cynical, thinking, what the hell? This is ridiculous, right? Well, this is what it's going to be the case too. We're going to determine what the legal standard is. Well, let's move on, and then I'll tell you more about this, right? Okay, so Derek was arrested, obviously, and charged with aggravated assault and murder. No qualms there. Now, he tried to claim a defense of insanity, but the jury rejected that. They rejected it because the judge told them, look, legally, insanity doesn't mean that you have a mental disease. It means that when you committed the murder, that you were at least able to appreciate what was right or wrong. So it wasn't that you had a mental disease when you committed it. Did you know what was right or wrong? All of the jury understood that Derek had severe psychological problems as a schizophrenic. They decided there was no evidence that he did not know his actions were wrong. So based on the psychologist's testimony, the psychologist said he knew it was wrong. He withdrew it immediately. Derek was found guilty and he was sentenced to life in prison without the chance of parole. Now, the reason why this is serious is because we know the level of inmates that have mental disorders, right? So this is always going to be a concern. So the last question here is, does the jury make the right decision? Now, actually, I have one more question after this. Did the jury make the right decision? They did. They did because the judge was very specific. The judge said, just I want you to make clear that when you go back and deliberate, you understand this is not about whether or not he had a mental disorder when he killed her. This is about, did he know the difference between right and wrong when he killed her? And the psychologist's testimony was enough for the jury to know, yes, he did. So this thing is tragic all along, right? I mean, you have somebody who had a mental disorder that committed a heinous act, and somebody who tragically lost their life, and we want something to be done about this. We're not quite sure what to do, and that's where the problem comes up. Right? Now, Professor Smith, a noted psychologist at Nearby University, he went on TV the night of Derek's conviction to complain about the barbarity of the legal definition of insanity. He even pointed out that the use of the word insanity is insensitive, to say the least. Even though Derek is mentally ill, when he was convicted of a crime. The definition of insanity used in most courts in the United States, but not in some other countries, Professor Smith claimed does not appreciate the level of compulsion that many mentally ill patients experience. In other words, he's trying to say the guy did not have any really free will here. He said that the civilized nations recognize that a person is not guilty if the act is committed is the result of a mental disease, as he claimed was in Derek's case. So the last question, and then I have some things to talk about, is the insanity defense, and you're not a legal expert, so just as a guess, is the insanity defense as used in most courts in the United States morally proper? It is, yes. I mean, if you lowered that from the threshold from knowing right to wrong to just having some sort of compulsory action based on a mental disorder, then it would be hard to really convict anybody that has a mental disorder. This is the catch-22. Have you guys heard that phrase before, catch-22? We know what it means? From the Army, that the only way you can get discharged is by an insanity plea. If you try to make an insanity plea that you're so terrified of losing your life and killing others, that's a pretty sane thing to say. So you must be sane and you can't get discharged. It's a catch-22. No matter how you want to get out of it, you're stuck. It's kind of under the colloquial sound. Turn your mics on. I have things I can say about this. What do you think about this case? Give me your impression. What do you hope would happen? What do you wish to happen? What do you think could have been done? This is just free discussion. You're not going to be wrong at this point.
Personally, like, I think it's interesting that this was like brought up because in like some of these situations, I always think about like what I would personally do. And like, I genuinely don't know what I would do if I was a psychologist because like, I don't know how I'd be able to tell if they were lying to me or not. Like, if he said he was fine, like, I don't know, I feel like I would believe it. But then again, like, I probably would have some sense of like, okay, he made a threat to like kill someone. Maybe I should take that seriously, even though he said no. I just like don't know what I would do.
Yeah, and it's not even a matter. I mean, I'm not playing gotcha. It's not even a matter of taking it seriously. It's like, well, what do you do?
Yeah.
You know, what do you do? I mean, part of this is like, our police can't protect people. That's not what the role is. I mean, I know it sounds terrible, when somebody's, you have to wait till a crime's been committed, but it's law enforcement, right? Or policing. I mean, they can't watch over somebody 24/7. What else do you have about this? I have a few things to say, but I want to hear what you have to say.
Well, what we talked about a couple classes ago about how if the psychologist does like breach confidentiality, then the patient like wasn't, let's say he wasn't even planning anything, then he could lose trust in like the doctors, and then he would never be able to like go to another psychologist and trust them and work out his problems, and it would just cause
It's
him
a
to
very, it's a very good point. I mean, even a Tarasoff case on as a side, what if this wasn't as bad as everybody thought, but he was playing it very cautious and breached confidence? Where is this going to put a person who's just been in treatment for schizophrenia for the last few weeks? Where now they're going to put them? They're going to go off their meds and probably never seek treatment. We don't know what's going to happen, and then who's going to be responsible for that? What else? That's a good point, though, Julia. Good point. I didn't even think about that.
What would
A little frustrated. Oh, go ahead.
oh sorry. I was gonna
No, go ahead,
ask,
Nasha.
what would take for the psychologist to breach confidentiality? Would he have had to said multiple times that he was going to try to kill the girl?
No, specificity. He'd have to, in other words, he'd have, the person have to probably do more than say, I'm going to kill her, and withdraw it immediately. Because pretend like somebody hired you, Nasha, to be the lawyer for this young man. You would say, well, no, I'm sorry. Did he say he was going to kill her? Did he say, I'm going to follow her to school and I'm going to use my dad's gun and I'm going to, when she does not looking, did he say that? No. What did he say? Oh, he said he's going to kill her. Oh, did he? Did he say anything after that? When he said no, he didn't mean he would never kill anybody. Oh, So when I say I could shoot you, all of a sudden now that's, you can hear a lawyer coming up with all of this. And my guess is, without knowing, we don't have access to the psychologist's notes, but they probably realize their hands are tied here. And they also probably realize, even if I breach confidentiality to play it safe, either what Julius is going to have, and that could be one of their concerns, or it could be that they're worried that they're going to get sued because they didn't hold confidentiality. And now what? And so what? He breaches confidentiality. This girl's safe, but the guy goes on the next one, and now he won't go back into treatment. This is not an easy thing. So it would take something specific, right? It's as you as a nurse, if somebody were to say this, if somebody would have said, I can kill myself, unless they were talking about some sort of sitcom, you would immediately bring that to your supervisor. But it may not go any farther because there's nothing specific there. But you need to take it seriously. We are taking it seriously, but we can't, we can't manipulate the legal system for every particular circumstance. We need something else. That might be tragic, but that's also, we're weighing two goods here: the person's privacy and public safety, and they're both important, right? What else? I have a few things I can comment on.
I also found it interesting when we brought up the psych ward, just because, like, for me personally, it feels like the point of therapy should kind of be to eventually have this person rejoin society without the need for therapy. So if it was possible, if the therapist saw that admitting them to a psych ward would like help in that goal, I don't see why they wouldn't admit him.
Well, I don't know. It could be because of the legal threshold to get them there. I mean, I'm not a lawyer or a psychologist, so I don't know exactly what that would entail. But I would imagine that psychiatrist, she'd have to make a pretty good legal case to have this person committed against their will. Because if she couldn't prove, I'm guessing, if they couldn't prove immediate harm to self or others, plus you may not want to go with that emergency. If you'd want the person there, because if you put somebody under an emergency and they don't seem to be a harm to the self or others, then it's going to be a limited time they're there and they're out. And then they're never going to get the treatment that you want them to get in the beginning. So if you have to legally compel them there, you might need the case. And this psychiatrist or psychologist may not have thought that they had enough there to put them in. Here's the thing. So my friend is a psychologist, right? He deals almost only in sexual violence, and most of his clients are in prison. So he does, jail cell evaluations and such. He also handles some pretty high-level sexual offenders. So I won't go into the details, but he's up in Boston, and a person was just released who was paroled, I don't know after how many years, a couple decades, who was a pretty heinous sexual offender. But they made it through parole. He actually was an expert witness on that criminal's behalf, and his testimony was something that compelled the parole committee to release this individual. Well, it was such a high-profile thing. This happened just in the last fall. He told me that he was met at the airport in Boston by the Boston Globe and other media. They couldn't believe this. Who is this person that would have, gave testimony to allow this, they call him a subhuman, out of prison, the sexual offender? And he just shrugged his shoulders and said, I can't talk about it. The case is, what the case was. But he goes, then they told me, speaking for him, would you let this individual around your grandchildren? He said, not in a million years. And they said, well, then how in God's name can you let them out of prison? He said, because the legal threshold is not whether or not I will let them around my children. That's not what determines whether or not they are safe in society. He said, so no, I would never let this person near my children, my grandchildren. But that's not the legal threshold. The legal threshold he met. If you don't like it, then you need to change the laws. But we're compelled in the legal system to go by what's precedent. So I'm just guessing, given the limited information we have about the psychologist, that they might have felt that perhaps, because think about this. Now, let's say that they did commit them. Let's say that they committed them, and individual gets out of their minimum that they spend because they were harmed to somebody else. And now, following Julia's idea, they no longer seek help. They go off their meds. and they go and kill 2 other people. Who's to blame now? I mean, the psychologist did what we probably would have wanted her to do. It may not have had that effect, but we would think she's ethically exonerated because she did something. But somebody might make the case that she made it worse. This gets very difficult to do. It's hard not to be cynical through all of this, right? So I told you my wife, when she first got out of college, she's very idealistic. She worked in a mental health unit at a prison, Muncie prison, all women's prison. So in the mental health unit, the individual's allowed to have a cigarette every hour. In solitary confinement, they're only allowed 1 cigarette a day. So you can imagine how hard these prisoners fight to get into the MHU unit. So what do? If you let them alone long enough, they'll grab a light bulb and start eating it. They'll pull staples out of a bulletin board and try to chew on them. Just name it. They'll do anything they can to harm themselves. The minute that they're a harm to themselves, they need psychiatric care. They come in an MHU unit. My wife says, they dealt with these people in individual counseling. And then once a week, the psychologist or psychiatrist comes in for the eval. They all sit in a room together. My wife said, psychiatrists ask them questions. Like dutiful little students, these people know exactly what to say. They say whatever satisfies the psychiatrist. Psychiatrist signs it off, says everything looks good, and walks out the room. My wife said it's the biggest sham she ever saw. And she also realized that you can't really help all people. That was probably the biggest thing she realized, that you never dehumanize individuals, but you get to the point where you realize the best you can do is maintain them from hurting themselves and others. Because even when they got out of prison, she said it was, without a joke, they would see them in 3 weeks. They would just, because that was their life. They were used to. I mean, there's other justice issues that go on here, right? There's nothing for them when they come out to help them. They wind up back in. So you feel like it's once you become a little cynical, you start to realize, what do I do here? And no matter how hard I fight, nothing's going to change. Well, I would imagine. Here's the other thing I didn't mention too. In that case study, the psychologist said that they don't get this frequently, but this is not an isolated case. They get a lot of people who threaten other people that are in their care. And if they jumped in every time somebody threatened somebody else, they didn't get a percentage, but they said it would be high. All right. So they have to only make a determination on the specificity of the threat. And if it's just a general threat that, yes, I'm going to kill somebody, it's not enough. It's not just who, how, when, that type of thing. And even beyond that, somebody in the last class said, yeah, but they already killed animals and this and that. Those are all red flags. Yeah, but they did that before they started receiving treatment. And in the 2 or 3 weeks since, the psychiatrist said they were doing pretty good. And they have recanted all that stuff and they no longer do. In other words, the psychologist here really, at least as far as the case study goes, thought the worst case scenario was that he might shout something at her, and didn't think anything else. Now, obviously that wasn't how it played out, but the laws change. There's not much you can do, right? Think of the mandatory reporting. When I grew up, I would never tell you over the screen things that happened to me. I don't mean anything like sexual abuse, but things that teachers and people in authority had said that today they would have lost their job in a heartbeat. Nobody said anything. Nobody would have believed you if you went and said, hey, this professor told me this. If I don't do this. Nobody would ever believe you. But because of the sexual scandals that have ensued, we're very hypersensitive. And I don't mean that in a bad way, right? Maybe we go a little too far, right? Sometimes people are being accused and they have no way to defend themselves, but people are believing accusers. So we now have mandatory reporting. So today, even if somebody says something, even if it might be, unless it's part of a joke, that I realize they're telling a joke, if they're telling me a normal conversation, I have to report it. I don't investigate it. That just goes off and goes. That never would have happened 20 years ago. Never. So who knows, how things are going to transgress in the next 20 or 30 years. Maybe some of the, glitches that are in the system, they'll find ways to fill them. I have no idea. It'll be the world you guys enter. It won't be one I have to deal with. So, but anything else on this? Let me stop the recording.